Good morning, everyone. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital, Unity Health Toronto, and also the Vice Chair for Quality and Innovation at our Department of Family and Community Medicine at the University of Toronto. I'm really pleased that our department can continue to bring you these sessions together with the Ontario College of Family Physicians, and I'm going to turn it over to Mekalai Kumanan to introduce the session. Mekalai?
Good morning, everyone. Welcome. Thanks so much for being with us today. We have a really great session ahead, and I just wanted to take a moment to thank our speakers for being here with us today. Next slide, please. And just a reminder, this is a Main Pro accredited session, and you'll receive details by email. Next slide. Okay, so I'd like to just move on to our land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite us all to reflect on the territories we are calling in from as we commit to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from Kitchener, the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the Chinantan peoples.
And I just wanted to share this reflection as we do our land acknowledgement. Our group has been consulting people in Canada across the country just about the future of primary care. And one of the special things we did was this community roundtable with First Nation, Inuit, and Métis living on urban and related homelands together with our partners at the Well Living House and the Indigenous Primary Health Care Council. And they really emphasized for us how important it is for our policies to really be flexible and protect Indigenous health sovereignty and self-determination, how we have to continually have processes for trying to unearth and address cultural safety and differential adherence to clinical practice guidelines, and how we have to include FNIM representation at all decision-making tables and really grow the size of Indigenous primary healthcare organizations to match the needs of their First Nation, Inuit, and Métis in Canada. So I wanted to just share some of those actions that that group recommended as we're trying to amplify their voices. So with the next slide, just wanted to remind folks that our session today is actually building on our previous community of practice sessions. And so you can find all of the sessions on our website, including our last session where we had Zain Shagla talk about many updates, including more details about RSV, which we probably won't be going into in as much detail today. Next slide. And of course, I'm really excited to welcome our panel today. We'll go to the next slide, and I'll just get them to introduce themselves one at a time. Janine.
Good morning, everyone. My name is Janine McCready. I'm an infectious disease physician at Michael Garron Hospital, or formerly Toronto East General in Toronto. And I'm excited to be back and chat to you guys all today.
Thanks, Janine. Daniel.
Hi, morning, everybody. Daniel Warshawski. I'm an Associate Chief Medical Officer of Health in the Ministry, and happy to be here always.
Thanks, Dan, for joining us today. Last minute addition, but always welcome. Joan?
Hi, all. I'm Joan Chan. I practice family medicine in Guelph, Ontario. And just in terms of my disclosures here, you can see that I also do some work with coaching and running workshops that are focused on rehumanizing our experience as humans in healthcare.
Thanks, Joan. Mekalai?
Hi there, everyone. My name is Mekalai Kumanan. I'm a family physician in Cambridge. I'm currently the president of the OCFP, and I serve as the chief of family medicine at our local hospital, neither of which poses a conflict for today.
And I've introduced myself, and you can see here that I'm lucky to get a number of honorariums and also salary support and research grants, but I don't think any of them pose a conflict for today. So just a reminder I see some people have already started using the Q&A. That's fantastic. So please put your questions in the Q&A, and Please share your comments, your resources, your reactions in the chat. The chat is a wonderful place to network, but please do put your questions in the Q&A. And of course, use a thumbs up to indicate if you like someone else's questions, because I will be prioritizing questions with that have the most thumbs up. And so without further ado, I wanted to turn it over to Janine, who's going to get us started. And then following that, we'll take some Q&A, and then near the end of the hour, we'll hear from Joan.
Okay. Thank you so much, Tara. Okay, so as I usually do, we're going to talk a little bit about COVID, and just to give us a sense of where we're at, looking at the numbers in the province, certainly in the hospital, we've felt it in the last few weeks of several patients admitted every day, somewhere between kind of 1 and 6 new admissions for COVID. And generally those people are admitted, because they have COVID or some complication related to it. And that kind of reflects this is the overall provincial wastewater. So there's been an increasing trend over the last several weeks, and we're yet to see where it's going to go. I think a lot of us are hoping it will level out, especially with the introduction of the new XBB containing vaccines, and then we won't see a further increase. But every season and every month with COVID is a different story, and it doesn't surprise us. So we're prepared for what's coming. Next slide. So I just wanted to quickly say, I know it's interesting because, we're now 3.5 years into this, and we're still seeing a very significant variety in presentations from people. And so sometimes that's related to people's host factors. So their comorbidities, their age, their baseline immune deficits. And then also now we have a total mixed bag of immunity. So there's many people that have some degree of hybrid immunity. There's people that have different numbers of vaccinations, from 1 to now 6 or 7 at this point. And there's people that have, just their response to those vaccines and the timing of the vaccines. And then there's also different variants that people are getting infected with. And then in addition, potentially how much people are exposed to the different levels of virus. So if you have a huge infectious dose versus you just are, exposed transiently. So all that to say is that it can still cause kind of a breadth of symptoms. So we have seen people still from asymptomatic or very minimal symptoms, there's just a little bit of runny nose, even in older individuals, to people with actually full-blown ARDS symptoms. And so in the last few weeks, we've seen a few concerning cases where people that actually have had vaccines and don't have, traditionally significant immunosuppression, they're, mid-70s with some comorbidities, but nothing certainly that would flag to me that they were very high risk, coming in with respiratory distress. So just that makes us think that it is still important to get these new vaccines into people. And as well, if you have someone that meets criteria for Paxlovid, which I know you've talked about several times in past sessions, but higher risk individuals, people with immunosuppression, still important to offer those antivirals. And although we might be done with COVID and want to move on, it's certainly not done with us. And we should continue to use the tools we have to prevent some serious illness in our patients. Next slide. Okay, so I know you delved into a lot about vaccines a few weeks ago with Zane, but this is just the new NACI recommendations. So they actually went as far as recommending the XBB vaccine to all age groups over 6 months of age if they haven't had COVID or COVID infection or COVID vaccine in the last 6 months, and then putting a particularly important emphasis on vaccinating the individuals below, which would all be members of groups that we would be worried about having more severe disease. So not going to dwell on that, but our fearless leaders at NACI have recommended it. So it's a good idea for everyone to go ahead and get this vaccine. And I know there's probably some debate against my colleagues, but I think that's been their recommendation they put out. Next slide. So I wanted to talk a little bit more today about 2 specific populations, one pediatrics and the other pregnancy. So I know you heard a lot about higher risk individuals. So how do you counsel your children your parents about getting their children vaccinated? And I think, I get this a lot of times, a lot of questions from friends, colleagues, and all of the school network that I'm still working with. So I think a couple things that I use to kind of frame those discussions, and even looking at my own kids deciding, risk benefits of vaccinating them. So these are US data, because we don't have this kind of data data available from Canada, but this is just looking at annual hospitalizations per 100,000 population for COVID-19, and also comparing it to some other infectious diseases that we now would routinely kind of recommend vaccinations for. So hepatitis A, varicella, and then different pneumococcal infections that we have vaccines for. Looking at the number of hospitalizations we had for those things before vaccines. So for varicella, it was between 29 to 42 per 100,000, and for pneumococcal about 40. And if you look at the numbers for COVID-19 hospitalizations, and this is over a period of 2021 to 2022, as well as 2022 to 23. So in the era of vaccines, and you're still seeing, 92 to 210 vaccines in that under 4 group, or admissions, sorry, in that under 4 group. And then in the 5 to 11 and 12 to 17, lower admissions, but still on average, probably as many or more admissions than we see for varicella and pneumococcal infection that we would routinely want to vaccinate kids for. So I think it just puts it in perspective that, it's, if we can, although the risk is low for children, 100%, the risk is also low for a lot of other things we vaccinate for, but it's very important still to prevent those infections, and to try and minimize harm to kids, because anytime a child gets seriously ill and is hospitalized, it's a big deal, and it would be much better to prevent that than to allow that child to get that sick. Next slide. And I think this just further drives home this point. So this is actually talking about deaths per year in the United States prior to recommended vaccines compared to COVID-19. So again, comparing hepatitis A, meningococcal, varicella, rubella, rotavirus, and then looking at deaths from COVID-19 in 2022. So in under 1, there was 156 deaths in the United States from COVID-19. And these are, when they looked at the data, they thought that was most likely from COVID, not just they had COVID while they were in hospital. Then 1 to 4 years old, 101, and then 5 to 19, 292. So again, for a whole country, low numbers, but for things we routinely vaccinate for, this is these are cases that we certainly should be trying to prevent. Next slide. And then this is just comparing our COVID and influenza associated deaths in patients or people under 19 years of age. So obviously 2020 and then 2021 and a little bit 2022, it's hard because we were masking and there was a lot of other social distancing and precautions. So there wasn't very much influenza, but the darker bars are COVID and the lighter blue bars are influenza. So just comparing the number of deaths of COVID versus influenza in these pediatric age groups. And so as we kind of have approached more normal in 2022, it's still, have been more COVID associated deaths than influenza. And, I know people probably debate about whether to vaccinate children for influenza, but I would certainly still recommend vaccinating children for influenza, especially that, the under 5 age group. And so there's probably similar benefit to COVID and similar risks to children in this age group. Next slide. Then this is also, I think a lot of people also assume, well, the kids that died or the kids that had complications or ended up in hospital, they had a lot of comorbidities. There were probably kids who are not like my children, but they actually looked at that. And among the children that were under 17 years old who died in hospital from COVID, 50% of them had no underlying conditions. So that is a pretty frightening stat to me, although the risk is low. If you can do something to prevent your child from ending up in hospital, ending up being sick, that is safe and effective, I think, that's where, as a parent and as a healthcare provider, I think it's important to take those steps. Next slide. And then just on the flip side, so what's the risk? Looking at specific serious adverse events in infants and children. So there's ongoing safety monitoring, and there's the AACIP just recently presented, all their new safety data when they were reviewing the vaccines, and there was nothing that was a signal for the 5 to 11. So in terms of the risk of myocarditis, they looked at this again. There was one other study that came out, and really almost no cases, very, very low risk in this age group. So on that risk side, not very much in that category. Next slide. And then this just looking at the older individuals, so that kind of 12 to 17 group where there was a little bit of a risk signal. So basically, it did find that the rates of myocarditis in adolescents and young adult males, so the 12 to 17 and then the 18 to 24 group, are lower with the bivalent or booster groups than they were with rates following the primary series. And the myocarditis risk is likely lower with longer time between the doses. So the rates of myocarditis were lower with extended intervals between the first and second dose for the primary series, and with longer intervals between your second and third, or third and fourth, or whatever dose you're on, the risks have been lower. And the majority of individuals who had myocarditis and pericarditis in those age groups have made a full recovery at follow-up. And important thing to note is that the risk of adverse cardiac outcomes was 1.8 to 5.6 times higher after actually COVID infection than having the vaccination among the males 12 to 17. So again, it seems like as we go on and the timing between the vaccines is much longer, the risk is lower, and the risk of someone having an adverse event from getting the infection is still higher from the vaccine. Next slide. So all that to say, what's important to talk about with families. So again, I always, when I'm, thinking of it for my own kids and talking to people and counseling them, I always frame it as a risk versus benefit. So on the risk side, yes, certainly low risk. Most kids will be just fine and they will have a mild illness, but there is that low risk that they could end up with serious disease. They could end up with hospitalization and even the low risk of death. And as we saw, about 50% of the kids that ended up dying in the United States had no underlying health conditions. So that's one important point. Then, I think our knowledge and our information is still evolving, but in terms of other long-term issues with getting COVID infection or with long COVID symptoms, there hasn't been any clear studies I've seen in children, but certainly some evidence with adults that the risk of long COVID is lower with vaccination. So another reason to get vaccinated. And then on the risk side, these vaccines are very safe. So really, almost no risk to getting the vaccine. And I think more and more, if we're thinking of it as something, routine that we put in our toolkit to prevent kids from getting admitted to hospital and kids from getting sick, the further along we're going to be in this kind of fight against COVID. And I think the one question a lot of people have is in terms of timing. So certainly, if your child has had COVID in the last 6 months or you've had a vaccine, no real benefit to getting a vaccine. And I wouldn't suggest that if you've recently had COVID. And the challenge is really knowing, well, did they have COVID? If you're not testing anymore and you're not, you don't know if they had it, then what's the risk? And so the risk is still going to be low. There's been most people don't know if they've recently had it, and there's been no increased safety signal in people having COVID and then getting a vaccine. It's just that you're not going to derive as much benefit from the vaccine. So if people know they've had COVID recently, then obviously less benefit to getting the vaccine. But on balance, that's kind of where I evaluate things. So now to just change courses a little bit and talk a little bit about pregnancy. There's lots of data, and I won't go through all of it in terms of safety of the vaccine in pregnancy and the benefits to pregnant women. But recently, the UK just put out a report from looking at a new surveillance report looking at the number of women that died over the last several years. And this was a few years back, but the causes of death in pregnant women in the United Kingdom, the COVID was actually the leading cause of death. So this is pre-vaccines, but again, so important for women to get vaccinated in pregnancy. Their immune system is down, their body is going through all kinds of physiologic changes, and they're going to be higher risk for infection and for severe outcomes. So on a really big population level, this is something that drives home that point. Next slide. And then this was another study that just came out a few days ago that I thought was really helpful. So again, we have lots of safety data, and this study was set up as a safety study, again, to give us more evidence that it's not only safe for mom, but it's also safe for baby. So they looked at 142,000 infants, 85,000 that had been received, the mom had received vaccine while baby was in utero, and 56,000 that were unvaccinated. And not only did it show that it was safe, but this actually showed a signal that it was perhaps even protective for the infant, which is amazing. We haven't seen that much, and I think further data needs to be done. And there may be some association between who was vaccinated versus who was not, but it actually showed a benefit to decreasing severe neonatal mortality, decreasing neonatal death, decreasing neonatal intensive care admissions, and there was no worsening or no change in hospital admissions after in the first 6 months of birth for those that were vaccinated. So really actually may protect your infant, especially in those first 6 months when baby's not eligible for vaccine and doesn't have any other protection from viruses. So something, again, to help counsel with moms if they're a little bit hesitant. And I think this is a reason to consider if they, a lot of people said, oh, I've already had my 4 vaccines or my 3 vaccines or whatever, I don't want any more. But if they're pregnant now, it will benefit them not only in this pregnancy, but it potentially will provide benefit for their infant as well. Next slide. So just a quick word on kind of other prevention measures, because we're still getting questions about, should I mask? Should I mask my kids? Like who should mask? I mean, at this point, it's a very, I think, personalized decision. When I counsel people and speak to people, I think it's all about their level of risk. So I think in general, most kids, if they're healthy and their immediate families are healthy, most people are not masking at this point, and I think that's totally reasonable. Kids took a lot of the burden of this pandemic on, and at this point, most of them are at low risk for infection. And if they're healthy and have normal immune systems, if they do get an infection, just like all the other infections that are circulating, it's going to be it's less likely to provide benefit for them. The people that I have longer discussions with and make sure that they feel empowered to mask if they want to, because I think sometimes we see the other way that people kind of feel embarrassed to mask now, is that is the vulnerable population. So anyone that's immunocompromised, if you're older, certainly then it does make sense if you're in a high-risk situation, so crowded indoor settings or with multiple people you don't know who may have symptoms or may be sick, benefit to masking, especially right now and probably for the next few months in the flu season, while we're seeing increased levels of viruses circulating in our community. And then a quick word on testing. So we kind of mentioned this, why should we test at this point, and then how do we do it? So I think testing is important for those who may be eligible for treatment. So again, important for people to seek treatment or to be offered treatment if they're in those high risk categories. And we've definitely had a few people who were admitted to hospital that were kind of told, yeah, you'd be recommended Paxlovid. And then they thought, oh, no big deal, or I can take it later. And then they got admitted, day 7 to 10 of their illness. So when you're speaking to patients, kind of outlining that this is only useful now, and if you don't take it now, we won't have these antiviral options later if you do get sick. So testing helpful for those individuals, and then also helpful to guide your next vaccine. So if people do have illnesses and you're planning on going to get your COVID vaccine next week and you're sick this week, would be helpful to do a rapid antigen test to see, is this COVID? Most of them are still, again, we see different things in terms of the positivity of them and the sensitivity and specificity. But if you are symptomatic and you do the test several days in a row, or your whole family does it, and everyone tests a couple days in a row, it should pick it up if it is COVID. And then where to find tests. So I just added some links there in terms of one specific to Toronto, they are still supposed to be freely available. I know some people have had challenges getting access to them, but they are supposed to still be freely available. So hopefully people can still access those. Next slide. And I think that's it. And I know I did use this on the last time because I just like it so much, because we're 3.5 years in and we're still talking about COVID. So those people that in January are like, are you worried about this? And I was like, yes, I'm very worried about this, when they built the hospital in like 6 days in China and people thought I was had lost my marbles. So I'll stop there.
Yeah, it's hard to think back in 2020, isn't it? And how far we've come. So it's really changed our world. Thanks so much, Janine. You've really gone deep on a lot of content areas that I know people have had questions about, and provided really excellent rationale for how we should be counseling kids and pregnant people in particular. and answered some of the questions that I've seen pop up already. What I'll do is I'm just going to go to the next couple of slides just to tell people about a few resources. So just a reminder that the OCFP has done an incredible job putting together fantastic resources, both for patients as well, so patient facing, as well as for yourselves as healthcare professionals. So stayhealthyontario.ca, great link to just like send to your patients, because it has some fantastic advice from family doctors about how to manage illness during this respiratory season. And then the other link there that will be put in the chat as well, it's from the main Ontario College Physicians, Family Physicians page, has a whole bunch of resources to support us as healthcare professionals, including information on vaccines, IPAC guidance, and posters for your office, for example, on masking. So those are just some of the resources OCFP's put together. And then I'll go to the next slide just for a quick update on RSV vaccine. So I know there have been some questions in the chat, and I will just say that if you want to know more about RSV in detail, Zane Chagla walked through it in quite a lot of detail around the rationale for the vaccine and how to counsel people. Well, we can talk a bit about that again today, but if you want a deeper dive, view our session from last time, which is about 3 weeks ago. But just to say that the RSV vaccine is available for private purchase in the pharmacy for people 60 years of age and older with a prescription. So you can provide your patients with this prescription. And then to make it easier for patients, pharmacists can't actually give it without a physician order at this time. However, when you prescribe the vaccine, the RSV vaccine, you can write on the prescription a direct order, please administer vaccine, and then the pharmacist can administer it. So that just can support help the patient not have to take multiple trips, go to the pharmacy, then come to you. Of course, if you want them to come to you, that's totally fine, but this gives you another option for your patients. I think they are working on amendments to pharmacist scope to be able to administer the RSV vaccine. So that's coming. So maybe we'll just stop slides, and I'm going to go to some of the audience Q&A right now. And maybe I'll, since we're on the topic of RSV, actually, I'm going to change my mind. I'm going to do some of the COVID ones first. So there is a COVID one related to some really timely news that has just come out. So one of our participants said, I read on CNN's top 5 that there's been a couple of studies indicating higher rates of stroke risk in elderly receiving both the COVID booster and the flu shot at the same time. Maybe Janine and Dan, are you able to comment on that?
Sure. So great question. I think as usual, the CNN kind of overblows things a little bit. So the study that they're specifically talking about now, I think it's only actually out in preprint. And so basically with vaccines, there's always they're very a lot of safety monitoring. And last fall, there looked like there was maybe a small signal of increased stroke risk. So there's been numerous studies and numerous investigations into that, looking at COVID vaccine alone, and then COVID with high dose flu vaccine. And with COVID alone, there's been absolutely no signal that they saw with the mRNA vaccines. And with the combination of them, a bunch of studies have actually shown no signal at all. The ACIP actually did a big deep dive just a few days ago looking at this, and they didn't see any red flags or anything they needed to draw attention to. And this new preprint, again, I don't think it's peer reviewed yet or actually published, and it showed a very small increase potentially just in the over 65 with the high dose flu vaccine and the mRNA vaccines. Again, the risk was very small, maybe about 1 to 2 per 100,000. And again, you have to balance that with the risk of stroke with flu or with COVID. And again, it was an observational study. So looking back at data, there might be lots of confounding factors. And the fact that we haven't seen a signal with other studies, I think we don't have a good answer. And to be honest, I wouldn't be overly concerned about it. And I think, again, looking at your risks and benefits, I think the benefit to getting both would be far superior than the benefit to not getting them. If you have a patient that is, has read this and is overly concerned, then I think if they want to split up the doses, completely reasonable to do that. And no, there hasn't been a signal with splitting up the doses. But I wouldn't necessarily counsel people to do that, especially if it's going to be a challenge for them to get both doses. And on a personal level, for my own parents, to be honest, I told them to go get both together. So, I was not worried enough about it to even on a, people that I love, to tell them to split up the doses.
Thanks, Janine. That's a really terrific answer. We have a question now, and I'm going to turn this one to Dan. It's about Paxlovid dispensing. So can you please provide an update on the progress with having Paxlovid dispensed without a positive test for current eligible patients, for example, in advance of travel? What steps have we taken?
Yeah, thanks, Tara. So at this time, the patient would still have to confirm that they had a positive test with the pharmacist. That can be a picture of the test. It can be doing it there. It can be telling them I tested positive, my doctor gave me this prescription. In terms of dispensing without a test, I would say stay tuned in the next couple of weeks. Tara, you already alluded to the pharmacy regulatory changes, and so along with those, there will likely be other changes to some dispensing as well.
Thank you, Dan. I noted just to say that so then our next question, I'm going to just talk about is there a preference for choosing Moderna over Pfizer or vice versa when both are available? And I don't know, Janine or Dan, if one of you wants to answer that. Janine, why don't you start?
I don't think so. Honestly, the whole Pfizer Moderna debate, when people have this personal preference, I don't really understand where it came from. I think it's marketing, to be honest. But no, I mean, in general, I think the only time potentially is if in that, maybe 12 to 17, 18 to 24 group, where potentially there's a slightly increased signal for myocarditis in the younger males. And again, as we space out the doses and all of those things, if you're not in your primary series, the risk is probably less. But those would be the only age groups where maybe, what I would maybe, a young male, maybe say get Pfizer instead of Moderna. Honestly, if I think whatever's available is great. And then potentially maybe for older adults, Moderna, because it's a little bit more robust. But again, we don't have, like with each new variant, we don't have the big comparison. So I think whatever they can get is probably best.
Yeah, I'll just say I totally agree. Like whatever you can get now is the main one. Like it was a bit different before when we had the 100 microgram Moderna. It was a much higher dose. It's all the 50 microgram now. So, before it's kind of comparing high dose, like our high dose flu, to Pfizer would be the regular dose. And so there was a little more evidence that for immunocompromised or older adults, it was probably a little more robust. At this point, like 30 to 50 micrograms is so close, we're not seeing the same difference between those products.
Thanks, that's really helpful. So Janine, you talked about how rats are still available, how they're still useful. I think though people are wondering, like, how good are they at detecting it? And I just wanted to flag for folks, I think the resources Janine shared are resources where you can get them for your patients. And then there's a different resource for you to get them for your practice. And maybe Dan, you can, so just before we go to the question of how good they are, maybe Dan, you could just remind people how they can get RATs for their practice to distribute.
Yeah, for sure. So RATs to get to distribute would be through the PPE supply portal, the one that's run by Supply Ontario. And I'm sure you've already put the links in the chat somewhere, Tara and team. If you haven't registered yet, there's a link to register, but that's where you can access, in addition to RATs, masks, gowns, all sorts of PPE supplies. There it is in the chat now. But that's where providers should be going to get RATs. For members of the public, that would be going to either the public health unit or other community sites that are offering. So it's different every community. Ottawa Public Library is giving out like hundreds of thousands right now. It's different in other places. And then healthcare providers, you can give out to your patients, other healthcare providers, physiotherapists, dentists, anybody else can get them to give it to patients as well.
Great. And so just to remind people, if you're having a hard time keeping track of all of these links, That's why this OCFP website is amazing, because if you go there, all the links are there on that one page, and you can find it. Janine, maybe you could tell us how good the RITs are at detecting it. I think we heard from Zane last time that they're still they're pretty good, but they might detect it a little later nowadays with the current strain or the current variant.
Yeah, I mean, again, I think it's kind of everybody's a little bit different. So the thing that I would suggest to people is, if you start to get symptoms, sure, do them, but then don't just do one test and stop. So do it like kind of on day one, and then if you have enough, you could do it every day for 4 days. But I would do it, early, and then do it a couple days in as well. So if you're negative, like I said, if you're negative for kind of between day one and day 4, and you've tested a few different family members in your house and everyone's negative, the likelihood that it's actually COVID, I think, is very low. 0, probably not, but again, very low. I mean, we saw this all along when the rat started to come out, is that people would say, oh, I did a test, and then they come and they would do a PCR and it would be positive. But I think making sure people are doing the test properly, and then if they're doing the oral nasal technique, like rubbing their cheeks, doing the tongue, doing the nose, or if they're actually having enough contact time in the nose and waiting enough time for it to work, so doing it properly. And then again, doing it multiple days in a row. And if they only have a couple tests, maybe do it day 1 and day 3 or day 4, and then testing a few people in the family. And I think that increases the accuracy of it. And if one person in the household's positive and they all have the same symptoms, then you likely all have COVID. It'd be unusual for you to have multiple viruses circulating in your home at the same time, although possible if you have little children at daycare, but less likely. So I think still a useful tool. Are they 100% accurate? No. And certainly if you are a very high risk individual and you're concerned and, reasonable and you're unwell, reasonable to seek medical attention and then get a PCR. But I think we for the most part, the rats are helpful.
Thanks so much, Janine. So I'm going to just change channels here for a minute and go to RSV questions. So as I mentioned, Zane Chugla covered these in detail, but I think we can answer a couple of these questions today. So the first one is just is RSV that bad for ages 65 and over? I've not seen or heard of this in my career until now. I'm worried the RSV vaccine is being pushed by pharma and could have some side effect signals, like how we found, AstraZeneca had, there was blood clots after it was rolled out. So are we too rushed? Am I supposed to give it to my patients today? What's the risk of delaying for a month? And then I think Jane also asked a very similar questions related to about RSV, the thoughts about timing and the target group, especially with respect to the COVID booster and flu vaccine. So yeah, Janine, what are your thoughts?
Yeah, great question. So, I mean, I think that we do see, especially older patients with comorbidities that are vulnerable adults, we certainly do see them getting sicker with RSV. And we can see, admissions to hospital and people, I think a lot of it's exacerbation of other medical conditions. So people that have COPD, CHF, those types of things, they get RSV, similarly if they would get other viruses and exacerbates that, and then they end up in hospital with a heart failure exacerbation or COPD exacerbation, or even RSV pneumonia. So certainly we do see it. And I think a lot of the time except for if they're admitted to hospital, we can't test for it. So you can't really, you don't really know on a community level, are those people, do they have RSV or do they have flu or some other virus? So certainly in the highest risk population, so you're kind of over 75, over 80, people with comorbidities, people in long-term care, I think there's certainly a benefit there. I think, the people that we see the most risk in is the very young children and the babies, and then our older individuals. For a healthy community dwelling 65-year-old, I think it's a kind of an individualized discussion. If they have no comorbidities and they're healthy, probably a fairly low benefit for them right now. But if they're 65 and they have CHF and COPD or multiple other conditions, then it probably is going to provide them with more benefit. And certainly from the evidence we have from the vaccine right now, a higher benefit than risk. But if your patient is nervous about it and they're in that lower category but eligible, I think waiting a month is not, it's not going to change things significantly. But in general, I think if people are eligible for it, especially those individuals in long-term care, I would definitely recommend it. I think the question right now I'm getting from a lot of people is, well, is it going to be covered, and how does that look like? Because we don't know how long it lasts in terms of seasonality. So should I get it now, or should I wait for next year when potentially it's covered? I don't know what's coming in terms of coverage. Dan might have an idea, but it is expensive for people to pay for. So again, if you're on that lower risk scheme and you don't have the funds to pay for it, I think it's a little bit less a priority versus if you're over 70 or 80 or have multiple comorbidities, then it would be a more benefit. Hopefully that's helpful.
Yeah, Dan, do you want to speak to that public coverage piece?
Yeah, happy to. So for this year, it's a relatively small public program, so it's going to be targeting all residents of long-term care homes. So that will be publicly funded for everyone who is in long-term care, and then higher risk residents in retired homes that are getting dementia care services. That's the initial rollout. Depending on uptake, like if only half those people want it, we may be able to get to other populations as well, but it's a very limited supply this year. So if there's very high uptake, like if 90% of them agree to get that vaccine, that's probably going to be the limits of who's publicly funded. But nobody community dwelling is going to be eligible in the public program for this year. Next year, totally different question, remains to be seen based on a lot of reasons, but at least for now, that's what we have coming up.
Thanks. And I wonder if either of you could provide an update on when you think the RSV vaccine for kids might be available in Ontario or Canada.
So a couple of things on that. So there's no vaccine for kids that's coming down the pipeline anytime soon. What we have is a new passive immunizing agent, so another monoclonal antibody. Many people on the call are probably familiar with the Synagis program we have now for high-risk infants. So the one that's been recently authorized by Health Canada is nirsevimab, or Beyfortus. It's not available this year, unfortunately, but we'd expect to have it next year, and it will likely replace the Synagis program. It's much easier in a lot of ways. It's one dose to cover you the whole season, might even cover 2 seasons. We're still looking at the evidence, versus the Synagis is one every single month. The other product that is coming probably very soon, that's just awaiting Health Canada authorization, is a maternal RSV vaccine. So it's been authorized in other jurisdictions globally. So that one we'll likely see for next year. And so, next year we'll have the older adult maternal and then a newer, better monoclonal antibody for kids. So it'll be a very different picture in terms of what's offered next season.
Great. And I'm going to clarify, my understanding is that it's, at this time suggested that people space the RSV vaccine from other vaccines just to understand if there is a safety signal, but it's not because there is any worry that there is a specific risk. That's my understanding from our previous sessions, but Dan or Janine, correct me if I'm wrong, because I think that question has come up as well.
Yeah, that's exactly right. So our Ontario Immunization Advisory Committee put a statement out on this. I can pop it into the chat now if that's helpful. Essentially, the trials did look at administration of RSV with standard quadrivalent flu and did not see any safety signal in terms of co-administration, but they didn't look at it with COVID vaccines or high dose or anything else. So this is like out of an abundance of caution and to better identify any potential adverse events that come from RSV, so we can attribute them to specifically RSV vaccine versus the other ones. We're recommending that 2-week window. But again, if you look at the OIC statement, it'll say like if someone is at risk, if they need to get all 3 of them at the same time, we don't have any reason right now to say that they shouldn't or can't. We're just trying to space it out if possible.
Thanks. I want to take a few questions that just build on the presentation you gave, Janine, related to pediatric population and pregnant population as well. So there's some questions just about like, what's the efficacy of this current XBB booster in the pediatric population? Like, what is the incremental benefit of another vaccination in kids if they've already had the primary series? I don't know if you have any thoughts on those questions.
Yeah, so we don't have, specific data on number of infections prevented or even the titers in kids. Moderna does have some clinical data for adults showing, and I think Zane went through a lot of this, showing the increase in neutralizing antibodies against the specific variants that are circulating. And so presumably that would be similar for children. But we don't have any clear data related to prevention of, number of infections prevented in children. the CDC and the OCFP went through, when they approved the vaccines, a lot of kind of cost effectiveness analysis and predictions for how many infections would be prevented. And I mean, based on what we know about COVID and how the variants change and how the protection changes, it should prevent, do more to prevent infections in general, because if you had a vaccine a year ago, it should still prevent against severe disease, but it's not going to do much to prevent you getting infected. So the newer vaccines that line up with the strains are going to help you to decrease your risk of infection entirely, and because of those increase in neutralizing antibodies, and it, depending on when the last one was, it should help further to decrease your risk of severe disease. But I mean, it's a great question. I think the risk for children is low, but again, looking at the safety profile and the risk benefit, if you have that option of further reducing the risk, I think, and they haven't had COVID or a vaccine in the last 6 months, I think it does provide some incremental benefit, but no hard data on that.
And what's the optimal timing for vaccines in pregnant people? Should it be the 3rd trimester, or can it be any time?
Yeah, good question. So really any time. And I think depending on, their last dose of vaccine, their last COVID infection, would get it before the 3rd trimester. And probably usually, I mean, again, everybody's so individualized and I don't want to give a blanket statement, but with pregnant people, oftentimes you're very nervous, obviously, during the 1st trimester, and there's no safety signal that there's any increase in miscarriage or anything like that with COVID vaccine. But I tend to still, with most of my interventions with pregnant people, I usually try to wait until after the 1st trimester just to minimize the anxiety. And then if anything does happen, people don't think, oh, it was related to this. So that's more just from a kind of practical standpoint. Safe to give it in early pregnancy, especially if someone was traveling or there was a risk. But generally, I usually will, if I'm doing any kind of intervention, will wait until after that period, just so if anything does happen, no one thinks it's related to the vaccine. And then somewhere in the 2nd, before the 3rd trimester, would probably provide the benefit for women, because when we did see women getting sicker during pregnancy, it was often during the 3rd trimester. So probably somewhere 2nd to 3rd probably 2nd would be best, because we also don't know the impact of maternal COVID infection on the infant. And that study that I went through a little bit, are there outcomes that we don't know about it, even if women have mild COVID infections while they're pregnant? Does that have some impact on baby? So is it useful to prevent any infection there? And so again, it depends on the timing of when they've had it previously, but if a woman had COVID or had COVID maybe 4 or 5 months ago, and they're pregnant, I would err on the side of discussing with them and giving them an additional dose before they deliver, because it may provide the baby with some additional benefit there. So even if they're close to that window.
Thanks, Janine. So I'm going to try and take 2 more questions, but we'll try, hopefully can answer one of them quite fast. So one person asked, the rapid tests we have expire in December 2023. Are the kits available with a further expiry date, or is it okay to use these beyond the expiry dates? I don't know if either of you have a quick answer to that.
There are kits available with a further expiry date. I would say, for ones that are expired, we really don't know how they're going to work. If it's the day after the expiry, it's probably still okay. If you're a couple months out, we just lose the ability to really say how sensitive it's going to be. So I would recommend getting new ones.
And then there is a question about Prevnar 20. And I just want to say that our hope is that in a future COP, we'll actually cover Prevnar 20 in more detail, probably in our December COP. But maybe one of you might have a quicker response, I guess, to should Prevnar 20 be recommended for those over 65? It may not be a quick response, but I thought I'd put that out to you.
I'll start and say, so NACI has recommended it for older individuals per the Health Canada indications, and even the guidance is technically for kind of programs like for a province put in place. It's a better product than the current pneumococcal vaccines we have. It covers more antigens. We know it does a better job of protection. At this time, unfortunately, it would still be private purchase because it hasn't made it into the public program yet, but we'll likely for next year see it entering the public program.
Thanks so much, Dan. I think that's a helpful answer. Okay, we're gonna go to our next speaker, and what we're gonna ask is Dan and Janine are gonna hopefully try and answer some of the other questions by writing in the Q&A, and if we have time, we'll try and get them to summarize some of the key things that they've been answering. And but we're at this time, maybe I'm going to go to the slides, Julia, and I'm going to turn it over to Mekalai to just give a quick update from the Ontario College, and then we'll turn it over to Joan to talk about how we can be gentle with ourselves and support ourselves during this time. All right, Julia, and then if you can get those slides up, then Mekalai, might be some technical difficulties, so turn it over to you.
I can just get started as we're pulling up slides here. So just a very quick update that we have been quite busy in the media through the OCFP over the past few days. You'll see on the slide we've done 11 interviews that resulted in 78 stories and quite a significant reach. And our focus really is on raising awareness about the crisis in family medicine and how it is actually progressing, unfortunately, in terms of the unattachment data. We have more recent unattachment data through our team at Inspire that shows 4.4 million people in the province without a family physician by 2026. And part of our goal in raising awareness around this is to really just emphasize the important role that family doctors play in the healthcare system. I'll just take a very quick moment to thank those of you who have participated. It's incredibly helpful. And I will take the opportunity to put a plug in for any of you who have not put your names forward but are interested in helping with media. I think our team will drop the email address into the chat, but you can contact us at media@ocfp.on.ca if you'd like to help.
Thanks so much, Mekalai. So I'm going to turn it over to you, Joan.
All right, thanks everybody. Hello, if you weren't here at the beginning of the session, I'm Joan. I practice outpatient family medicine in Guelph, Ontario, and my Tigger decorated office behind me, I'm here now. So I was asked originally actually to talk about a human-centered approach to paperwork because it's a bit of a passion of mine, as nerdy as that sounds. And I thought, especially now we know we're talking about how to stay human in the midst of respiratory illness season and vaccines just coming off the shelves, being encouraged to come into our offices. And so I wanted to talk to everyone about practical human-centered ways to create a surge capacity. I like the term surge capacity because when you think about it, this is a seasonal surge that we have every year. If you look at other industries, like for example, Walmart and other big box stores, right now are probably already or planning to hire tens to hundreds of thousands more employees for their seasonal surge. But in our system, that is not an approach we take. We have the same number of humans and are being invited to do a surge of additional work. Next slide, please. And the problem with that is doing it all is literally impossible, even before everyone got sick in September, and then a bunch of new vaccines hit the market and made things even more complicated for us, right? And this is just like factual math. Like I like to cite that study that said, if you actually break down how much time it would take to follow all the different guidelines for primary care, it would take more than 24 hours. And that was like before COVID and new vaccine guidelines came out. Like it's even more impossible. People are handing out rats, but they are not handing out Hermione Granger time turners. So like we've got to make another way to do it. Next slide, please. And so one thing I'd want to frame it is often our brains, high achievers, perfectionists, type 8 personalities, we look at this giant to-do list and we know we've already failed and we feel like failures. We can feel defeated. This can burn us out thinking we'll never do it all. So one quick way to just even reframe it is if you see one patient today, that is valuable and more than enough. If you actually see no patients today, today's your day off and you spend time restoring your body and connecting with yourself, that is enough. Everything we do in our work is beautiful and valuable, but you as a human are enough even if you don't do it. So like, why don't we start that as a baseline? And then anything we do is this beautiful bonus extra gift that we are offering to those that we are passionate to serve, right? Next slide, please. So something that I've been trying on and putting into practice in my own life is, what if our baseline schedules before the fall season were actually set so we were working under our maximum capacity, so that during times like this, we have space physically in our schedule and space in our minds and in our bodies to consider what kinds of extra work we might take on. It may sound radical and like slightly offensive to consider, but when you think about it, just mathematically, doesn't it make sense? If you have a cup of water and you're always trying to pour more in and it's spilling over the edges, that's not a system that's going to work, right? And so the real question is to think practically and reflectively, what would have to change in order for your schedule to actually reflect this? And I'm going to give you practical examples. Next slide, please. Before I do, I just want to recognize a lot of times when we think about shifting our workload so that we're actually honoring our own capacity, it feels selfish. It feels like, what about altruism? What about duty? Family doctors these days, they don't work hard enough, etc. And so I want to offer a counter narrative, which is that honoring your capacity is good patient care. When you are a restored, resourced human being with your brilliant mind and emotional bandwidth, you make less distracted mistakes. So that's a cool one. More emotional bandwidth to actually hold space for patients who are really suffering right now, because I don't know if you've noticed, but the world's like slightly on fire, literally, and all the other ways, right? You actually have more capacity for creative decision making because we're not doing simple math anymore. The calculus of how to get a person a simple vaccine has gotten complicated. So we need to be thinking deeply creatively, and we can only do that from a resourced state. And if nothing else, honoring your capacity equals you don't leave medicine. And as we just saw in that previous slide, people are honoring their capacity because they've worked for so long at max and over max that they're leaving. And I honor everyone's individual choice about that. But if we want some family doctors, those that are interested in staying, I'm probably midway through my career. I'm not interested in leaving early. I'd like to stay, but I know the ways that we've kind of had modeled or encouraged to work, it's not going to cut it in today's world. So if we want to stay and do good work and feel good about our work, it's time to shift. Next slide, please. So I want to offer you this, if you want to screenshot this or come back to it. This is a way that you can separate different tasks on your, I almost encourage you to make a giant list of everything you feel like is very important that you should be doing and are right now beating yourself up because you might make time to do it, including going to the dentist, right? Everything that you think has to be on your list, but is impossible to be on your list. And we're going to segregate it into these 4 categories to make things a bit simpler for you. Next slide, please. So I wanted to give you some practical examples. I am not suggesting this is where you put things in your quadrants, but I'm giving you some examples of how I thought it through. And then I think actually we're going to all put slightly different things in these quadrants, and that's good. That's diversity. And that actually means that there's a little bit of work for everybody, right? So starting with the upper left one, because it's the most important one, when you look at your list of all the things you think you absolutely have to do and feel deep shame you're not doing, what do you want to quit? Or if quit feels too dramatic, what do you want to at least pause for this surge season? And even use that as a beautiful excuse as you write your email to, for example, the committee that you were really interested in and excited about 2 years ago, but now you feel awkward and embarrassed to still be on, even though you don't even really know what's happening or you don't have any bandwidth to contribute meaningfully. What if you just go ahead and send I'm going to pause for the seasonal surge and I will reevaluate my capacity to participate in this work afterwards. If you need someone to give you permission to do that, I am a fellow colleague saying, maybe that's one thing. Not all committees, but the ones that you don't enjoy being on, right? Another thing that you could consider pausing, and that I have had much joy in considering pausing, is the work that specialists ask us to do. And we have that fabulous new CPSO guideline that gives us some bandwidth and some permission to do it as well. One of my colleagues actually, received a consult note back from a much respected colleague who then said, could you please order this blood work, do this test, do these referrals to subspecialists in my same area? And she wrote a really beautifully worded letter that was very respectful, very showing deep gratitude for the work this specialist was doing, and cited the CPSO guidelines and said, I will not be doing any of this work. Okay, thanks, bye. And it was like, I actually like did a little happy dance and like we made it into a stamp because it just feels like liberating to know we're allowed to say no to things, even things that are important, even things that very important people tell us we must be doing. So things that I want to say in this category, if you cannot think of any reason you're still wanting or trying to do this thing other than you're afraid someone's going to be mad at you or people are going to judge you, but otherwise it brings you no joy, it is draining your day, permission to consider pausing it, if not quitting it. Going to the lower left quadrant, is there stuff that you're like, no, I do want to have some responsibility. I like offering this to my patients, or I like doing this in my life, but I just can't stand doing it personally myself. What about delegation? Delegation takes time. It takes a different kind of resource sometimes, whether it's money or training someone, but it can be a well worth investment. If you don't have capacity this season, think about doing it in the spring or summer for next fall, right? So one thing I'm personally delegating is a lot of my forms. There was a nurse in my office who was interested in more hours, and we decided to train her up to fill out forms on our behalf. She calls patients to clarify dates. We still see the forms and do an edit, and we send them out. It's an ongoing process, but it's felt delicious because I personally kind of think that forms should not be allowed, just generally. I'm very anti-form these days. Another thing that I delegate is parts of my charting. And this I actually don't even do to another human. I do it to a computer program because I've been using an AI scribe and absolutely loving it. So it costs a bit of money, but it also brings me so much joy to have a little robot friend in my room with every patient. And often the little robot, the AI scribe, picks up more details than I would have otherwise, which is very fun. The most important thing really is that lower right corner, which is protect. What are the things inside of medicine as well as outside of medicine that you feel like you are losing touch with, but are actually the things that nourish you, that replenish you, that are going to give you those resources to do the important work that you want to do? So for me, mine is patient connection. It's one of the things I need to know. So that's like my AI scribe means I can actually look at the eyeballs of my patient and connect and focus with them without having to be my own like court stenographer. It's fabulous. I want to have just enough patient clinical time so I can remain connected. I've noticed if I try and see too many patients or do too much clinical work, I stop caring after a while just because my emotional bandwidth has been maxed out. So it's interesting. One of the reasons I started to pare back some of my clinical work, and for me, what I've done is hired nurse practitioners to help still have access. It's just one way that you can do it, of course, but it actually means that I am prioritizing patient connection with the patients I can see while honoring my capacity. One thing I'm very interested in protecting for myself is my personal rest and acts of pleasure in and out of medicine. We think of those as selfish. We think of all the socialization that those things are like illegal and not allowed. I mean, you're a bad person. Those are all just like late stage capitalism trying to keep you hustling. And so what about if instead you honor the fact that you are a human being in a human body and knew that that was actually part of a professional competency to resource yourself well enough to connect with the patients you do see. And then everything else goes in the bare minimum, which is the upper right. So for example, your inbox. Have you noticed that the inbox keeps flowing in whether you work really hard on it or not? So what if you set aside, I recommend at least 30 minutes of uninterrupted inbox time, minimal distractions, maybe the new Taylor Swift 1989 Taylor's version playing in the background to make it a bit more fun. You sit and do one inbox item at a time. You get through as many as you can. And even if you don't touch your inbox for the rest of the day, those were valuable pieces of patient care. And that can be what you call your like baseline minimum. And that gets to be amazing patient care. If you have extra time, bonus, but that's your measure of success, is that bare minimum time in your inbox, because inbox is like the laundry. Sometimes you got 10 loads, sometimes you got 1 load. You can't measure your success as a human based on how much is in your inbox or you are done for. And then everything else, how do you do things bare minimum? How do you just like get it out the door? See copy of chart, sign the prescription renewal as quickly as feels good. Like, how do you do everything like B- or less quality? Because it just doesn't deserve that much of your time, right? You're protecting the things that actually deserve your time, and everything else gets like pretty solid, whatever kind of status, right? One thing I like to say about this category is a mantra I repeat to myself: timely, not urgent. In family care, in family practice in particular, we do a lot of timely care. Nothing is urgent. If it's urgent, they've come to the wrong door. We will get to it when we get to it, and that will feel good when it's done. Timely, not urgent. If we hold urgency in our bodies, that is what drains us out. I know the patients are screaming at us, the colleagues are screaming at us. It feels emotionally urgent to them. We cannot take that on ourselves, or now we're all sunk. So that's the end of my presentation. The last slide just lets you know if you want to connect with me on Instagram, or I have a podcast. I actually ironically have one about surge capacity this week. So if you want to hear more details of some of like the specifics of how I'm doing it, I'm happy to share that. Yeah, and otherwise that's it for me. I think I saw some questions. Should I answer them, or what happens now?
Yeah, thanks so much, Joan. We're running at the end of our session, but let's go for just a few more minutes. And I just will say there's so many validating comments in the chat. People really appreciated the tips, the sentiments that you shared. You really, I think, clearly connected with how other people are feeling. People talked about how this mantra, timely, not urgent, really helpful. The idea of delegation, that taking time for yourself, like blocking off. Somebody said they block off time to do a hike, and that's really been helpful. I did that myself actually recently in the fall, and it really helped me. One practical question for you is about what scribe you're using, Joan. I think people were interested in which one it was.
Yes, I'm using AutoScribe, which is put out by Mutual Health, which is actually, it's like a Toronto family physician. I know there's a number out now, and I've seen discussions like trying on different ones. I think is good to see what's a good fit for you. But if you're looking for one that at least one other family doctor is using, AutoScribe. But usually if you search Mutual Health, I'll put it in the chat, the spelling of it. I've been very happy with it personally.
Wonderful. Yeah, and please do check out Joan's podcast. Feel free to add some of those things to the chat. Joan, I think people just really appreciated your presentation. I'm going to just wrap up here with some of the outstanding COVID questions and things that Janine and Dan have been answering. I think Dan had to leave, but Janine, if you're still on, it would be great to just wrap up with a couple of things. I will just say I've been looking at some of the things you've been answering, and just to say that you've talked about how Paxlovid is safe for women who are pregnant, how there's no long-term risk of cancer that's been shown with the COVID vaccines, that there's no long-term safety risk that we've seen to date with kids. So I think those are some of the things that I've seen you already respond to. There's just a couple of questions that were and a couple of questions for you, Janine, and then one actually for you, Joan, that I'll flag. So for you, Joan, people want access to the letter or the stamp. So hopefully you can share that with us, and
Yes.
then we'll share it out with everybody who attended. And then for you, Janine, one is just, when we're providing the COVID shot, does there need to be an interval between a Prolia shot or methotrexate or something like that?
No, I mean, generally, whenever you're thinking about like chemo or any kind of immunosuppressive agent, I always think of like, when would they be at their like lowest amount of immunosuppression so that the vaccine's more likely to work. But it's so hard when people are on continuous medications, because that's the goal of them, is that they don't have peaks and valleys. So I don't think I can't think of any specific timing for those. So I think when it's appropriate for when it works for them, basically. But no, nothing I can think of.
Right. And then I think the other one is so I think that we've actually answered most of the COVID questions now. There is a question just about Paxlovid decreasing post-COVID symptoms. And do you know if there's any evidence for that, Janine?
Nothing concrete, or actually, that I would hang my hat on, that I've seen. I know that a lot of people want to believe it does, because that would be wonderful, but I have not seen anything that I would say clearly, yes, it shows a decrease. Certainly there was something out new about vaccines and decreasing long COVID, but I have not seen anything that I would really be like, yes, this is good evidence that it decreases, Paxlovid decreases long COVID.
Great. So Julia, I'll just get you to put up our last slides. I think people feel really appreciative of the information we shared today in your talk, Joan, leaving us on such a positive note. I just want to remind people of some resources as we close off. If you have people who need longer time to just talk about the benefits of vaccination, this VaxFax clinic continues to be a wonderful resource. Next slide. I wanted to remind people still of this study, Can Treat COVID, run by my colleague, Dr. Andrew Pinto. So if you have patients who are eligible for Paxlovid, they actually do a wonderful job counseling them, mailing them mailing them the medication. It is a randomized trial, but it will actually help us understand a lot of those types of questions people are asking about. Next slide. And a reminder that some people have been wanting to know, like, can I test my own patients for these different viruses? And the one way you can is if you are a Sentinel practitioner. So you can sign up to be part of a Sentinel surveillance network. Next slide. And wanted to remind folks that Family Medicine Summit is coming up, and I saw that Haley Wickenheiser is going to be one of it's going to be the keynote speaker, which is pretty exciting. So you can find out more information at the website. Next slide. And did want to encourage folks, lots of great questions about system advocacy and thinking about the third year and how we can, change the primary care system we're in. And some of that is through us, stepping up into more and more leadership roles in the system. And so this is a wonderful opportunity that the OCFP is offering to enhance your own leadership skills in partnership with Wapman. So, and our last slide is just about our next session. The next session on Friday, November 17th, 3 weeks from now. It'll be moderated by my colleague, Dr. Ali Damji. We'll have Gerald Evans here talking about COVID-19. And we'll also actually be talking about the Ontario Structured Psychotherapy Program. So something really relevant to so many of us because of this, large amount of mental health and addictions that all of us care for in our practice. So thank you again for everything that you do. Remember, as Joan said, you're enough. You're enough. And so take care of yourselves. Hopefully everyone can enjoy a fall hike, and hopefully people are enjoying some of the lovely fall weather that we've been having. And we look forward to seeing you in 3 weeks. Take care.